Welcome everyone. A very good morning to all of you to this session in case-based scenarios in medicine part 6. My name is Dr. Jhanvi, and as usual we are going to be having the series of case-based scenarios in medicine. So first of all, I hope that all of you all are able to see me and hear me well. If the streaming is okay, please leave a thumbs up. I will be able to see it in the chat box. If the streaming is absolutely fine, guys, you can leave a message in the chat box and I will be able to see it. Okay, yes. Awesome. So I see that the streaming is fine. You all are able to see me well. There is no problem with it. So we can begin with our class for today. Okay, so today's class, I have a few case-based scenarios which will be towards the end of the class. And in the beginning, we are going to be revising some important ECGs. So yeah, so in the beginning, we are going to be revising a few ECGs. Now, ECGs are very important because they will come directly as identification questions, as well as later on they can come as case-based scenarios, part of it. So first we'll revise the ECGs and then we will do the case scenarios, right? So I am an MBBS MD in anesthesiology. This is the Telegram channel where I post the links to all the classes that I take. So I highly recommend all of you guys to make sure you're part of the Telegram channel so that you're aware of the class timings and the links of the class. And on the 26th of February of at 9 a.m. we are going to be having the All India mock test. Now this mock test is super duper important because a lot of you have slacked off after the NEET PG exam has been postponed. So I want you all to get up, give the test and see where you stand, what are your good subjects, what are your bad subjects, and what is the thing that you need to put in the last mile. Okay, so giving a mock test will also sort of give you an idea where you stand amongst your peers, and it will tell you your weaknesses and strengths. Along with that, we also have the NEET PG combat test. As you know, we make combat very interesting. So on 19th of Feb at 6 p.m., you can attempt the combat test and you can actually end up winning a tablet. Even I am thinking of giving this combat to win that tablet, smartphone, Amazon vouchers. So many exciting gifts are there. Now, the Plus subscription on Unacademy will help you get access to both live and recorded classes. You can learn from India's top educators. And the iconic subscription is a partnership between Unacademy and PrepLadder, which will help you get the recorded lectures of PrepLadder and the question bank along with the live lectures of Unacademy. These are our FMG toppers. We also have so many test series going on right now. So we have the educator curated test series in which there will be the top questions of every subject, which is specifically made by that subject educator. So in fact, on the 18th of Feb, there is educator curated test series of anesthesia. I will be posting the link of that too on Telegram. And you can again win Amazon vouchers worth 5,000 rupees if you top in that test. If you would like to try Unacademy for free, you can come on to our special classes, which will give you polls, live interactive classes, raise a hand option, and also lecture notes in the form of PDF at the end of the class. And we have all these plus classes. The target next 2023 subject-wise batch, NEET PG 2022 all educator revision batch, Focus FMG comprehensive batch, Focus FMG December comprehensive batch, the NEET PG plus subscriptions as well as iconic subscriptions. Both of them are highly discounted now, so it's the best time to buy them. This is my anesthesia test, which will be on the 18th of Feb. And of course, if you would like to buy the Unacademy Plus subscription along with all the various offers that are available, plus an add-on on it is if you use my code Dr.Jhanvi Live, you can get a discount on your Unacademy Plus subscription. So let's begin with our class for today. As I told you that first we will be revising a few ECGs. Now I'm not going to give you any options in the ECG because you need to know it. Pat karke you should be able to answer all the ECGs. There is no need for thinking, ruling out options and coming to the answer. ECG is something that all of you all should know very well. So first question for today is, look at this ECG and calculate the heart rate. Look at this ECG and calculate the heart rate. Anyone? Okay. So whenever you have to calculate the heart rate in an ECG, the first thing that you will see is the rhythm of the ECG, correct? So you have to tell me whether this is a ECG with a regular rhythm or an irregular rhythm. So can anyone tell me whether this is regular or irregular rhythm? You look at your P waves, sorry. You look at your P waves, you look at your QRS waves. After every P wave or QRS wave is followed, and you see the RR interval. What will tell you whether your rhythm is regular or not? If the RR interval is remaining constant. Okay. So here you see the RR interval is constant. How much is the RR interval over here? Let's have a look in the form. There are 1, 2, 3, 4 big squares. So the RR interval here is 4 big squares. Correct? Now, what is the formula for calculating the heart rate whenever you have a regular rhythm? It has to be 300 divided by the number of big squares in the RR interval. Correct? So, it is 300 divided by 4. So, how much is 300 divided by 4? It is around 5 beats per minute. Now, suppose you don't want to calculate using the big squares, there is also a formula using the small squares. Okay? So what is the formula using the small squares? 1500 divided by the number of small squares in between in the RR interval. So that will also give you the answer of about 75 beats per minute. Okay. So whenever you have a regular rhythm, these are your ways of calculating the heart rate. Okay. Now moving on to our next question. Calculate the heart rate in this case. Calculate the heart rate in this case. Have a look at the ECG over here and try to calculate the heart rate. So, whenever I give you another question to calculate the heart rate, as we learned earlier, we have to see whether this is a regular rhythm or an irregular rhythm, correct? So, if you look at the RR interval over here, the RR interval is constantly changing, correct? So, this is a irregular rhythm. This is an irregular rhythm. So, in an irregular rhythm, how do you calculate the heart rate? What is the formula for it? Does anyone know? Okay, Nimesh and Deepthi are saying that the answer is 80. That is absolutely correct. Okay. So what you have to do in an irregular heart rate, you have to calculate, just take 15 big squares. Okay. So you count from here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 and 15. Okay. Now these are 15 big squares. So here I will mark a big line like this. So from 1 to 15, you have to count how many okay. Try to identify the abnormality in this ECG, guys. So whenever you have to identify abnormality in any ECG, there is actually a pattern that you have to follow. Okay. So you have to first look at the rate. So if you see the rate over here, it should be around 300 divided by 1, 2, 3, 4, 5, around 5 small squares. So the 5 big squares. So the rate will be around 60 beats per minute. Okay. Then after that, you have to calculate the rhythm. Yes, Tharani, I will explain it again. Okay. Then you have to see the rhythm. So rhythm over here, it seems regular only. The RR interval seems constant. Then you look at the axis. Okay, you look at the axis deviation, if any. Now, how does axis deviation come? We'll be studying in the next ECG, so I'm not going to teach you that over here. Now, once you have seen the rate, rhythm, and axis, then you go to each and every component of the ECG. Okay, so you will look at the P wave, you will look at the QRS complex individually, and you will look at the ST segment, and you will look at the T wave. So that is what you should be focusing on. All right. So P wave over here looks normal. Now QRS complex, if you look over here, is the one that is problematic. So what can you see in the QRS complex? If you look at the pattern in V1, the pattern in V1 is nothing but a wide QRS complex. The pattern in V1 is a wide QRS complex. Okay. So wide QRS complex may, what is the possible option? So wide QRS complex में the possible option is presence of left bundle branch block or right bundle branch block. Either of these things could be present. Okay. Now, how do you identify whether there is a left bundle branch block or a right bundle branch block? So it's very simple. You just need to remember the words William and Marrow. Okay. So in V1 and in V6, see what is the pattern of the QRS complex. So if you are getting W pattern in V1 and M pattern in V6, that means you have left bundle branch block. Okay. If you are getting M pattern of QRS complex in V1 and W pattern of QRS complex in V6, that means you are having right bundle branch block. Okay. So what are we getting over here? If you look at this QRS complex, this is a M pattern. Can you see? This is a M pattern. Okay. So in V1, we are getting M pattern, and in V6, we are getting W pattern over here. So M pattern and W pattern. So this is nothing but right bundle branch block. So this is RBBB. So the diagnosis over here is RBBB. Now, why do you get a wide QRS complex? If you look at your heart over here, okay, so this is your SA node. The impulse goes from your SA node to your AV node, from AV node to bundle of His. From bundle of His, it goes to left and right bundle branches. Okay. Now, if there is a block, suppose this right bundle branch block is there. So this bundle branch is not working. So instead of spreading through the bundle branch quickly, the spread of your impulse in the ventricle will take place through the ventricular muscle because the bundle branch is not working. So if the impulse spread is taking place from your ventricular muscle, this ventricular muscle is not highly specialized conductive tissue. It's a very slow tissue. It is made up of, it is going through normal ventricular muscle. So the spread of the impulse will be slow. So as a result of the spread of the impulse, it takes time for the entire ventricle to get electrified. And because of that, the ventricular contraction takes place slowly. So you will have a slow right ventricular contraction and a left ventricular contraction, and then sudden, and because of there being discordance between the right and the left ventricular contraction, you will have a wide QRS complex. Okay. So instead of a narrow, quick QRS complex showing both ventricles contracting, you will have a widened QRS complex showing a slow contraction of both the ventricles. All right. So that is why you get wide QRS complex in case of bundle branch block. Okay. So thoroughly, absolutely, I will explain it to you of this irregular rhythm. Whenever you have an irregular rhythm, how do you identify an irregular rhythm? The RR interval is constantly changing over here, correct? So that is your irregular rhythm. How do you calculate the heart rate in case of an irregular rhythm? You count 15 big squares and mark a line. So from 1 to 15, you can see this, and you just mark a straight line. Now in these 15 big squares, you have to count how many QRS complexes are there. So you have 1, 2, 3 and 4 QRS complexes, and you multiply that by a multiplication factor of 20. Okay. So that is the fixed multiplication factor. So what you have to remember is 15 big squares QRS complex and multiply this by 20. So this is going to give you the heart rate of this patient. Okay. So that is how you calculate an irregular heart rate. All right. Moving on to our next ECG. Now, identify what is the abnormality in this ECG. Again, follow the same thing that I taught you in the previous slide, rate, rhythm, axis. then go individually to P wave, QRS complex, ST segment and T wave. So try to identify what is wrong with this image. Come on guys, it should not take you more than a minute to identify what is wrong with ECGs, okay? And that's why I'm not giving you all any options also over here, because I want you all to start looking at the ECG on your own and arriving at what is the problem with it, instead of looking at the options and then ruling it out. Okay, Staphylococcus ST elevation is wrong. There is no ST elevation over here. Alright, so let's have a look at it together. So first, let's decide if there's something wrong with the rate. So the QRS complexes, as you can see, are regularly placed. There is around 1, 2, 3, 4. So 4 big squares in between 2 QRS complexes. So the heart rate must be same, around 75 beats per minute. The rhythm, again, the QRS complexes are regularly placed. The RR interval remains constant. So the rhythm is regular. And next thing you need to see is the axis. Okay. So the axis, if you see over here of this, is not a normal axis. How do you see the axis deviation? So whether your heart is having left axis deviation or right axis deviation. So how do you see that? You have to look at lead 1 and you have to look at lead AVF. Okay, those are the two leads you need to see, lead 1 and lead AVF. Now, very easy. In right axis deviation, you will have the QRS complexes reaching each other. Okay. In left axis deviation, you will have QRS complexes leaving each other. So this is how you need to remember: R for reaching and L for leaving. Now, what do you mean by reaching and leaving? Now, if you look over here at this QRS complex, the QRS complex over here in 1 is positive and in AVF is negative. So both of them are moving away from each other. They are leaving each other. So when I say they are leaving each other, this is left axis deviation. Okay. On the other hand, if your QRS complexes were reaching each other, if in 1 it was going like this, if your QRS was negative, and in AVF, if your QRS was positive. So in that case, the QRS complexes would be reaching each other. So that would be right axis deviation. Okay. So the problem over here is nothing but left axis deviation. All right. Okay. Moving on to our next ECG. Identify what is wrong with this ECG. Again, something that we have recently seen, so you should be able to identify it well. Very good, Deepti Sharma. Very good. This is left bundle branch block. Okay. So if you look at each and every ECG over here, so let's have a look in the way I taught you all. Rate over here, the RR interval seems quite regular. So if we calculate the rate over here, 1, 2, 3, 4, so around same 300 divided by 4, around 75 beats per minute. Okay. Rhythm, as I told you, RR interval is regular, so rhythm is also regular. Axis, if you see over here, the axis is showing, what is it showing over here? The axis 1 and AVF. The QRS complexes are leaving each other. Okay. So this is left axis deviation. And then you have to look individually at each of the things. The P waves look fine. P wave, there is no problem. The QRS complex is the problematic part over here. So if you look at the QRS complex, it is very obviously wide QRS complex. Okay. your normal QRS that is there is 2 to 3 small squares. Barabar? So that is around 0.08 to 0.12 seconds. But here you can see that the QRS complex is quite wide. In fact, it is 4 to 5 small squares. So what is wrong if the QRS complex is wide? This is what we discussed before. There has to be a bundle branch block. Now, again, you need to know whether this is a left or a right bundle branch block. So we'll go with what we learned, William and Marrow. So if I look at my V1 and V6, correct? So V1 is giving me a W pattern. Barabar? V1 में I'm getting a W pattern and V6 में very clearly I'm getting a M pattern. छोटो सा M है, but it is seen. It's still seen. Okay. So V1 में W pattern and V6 में M pattern. So what am I talking about here? I'm talking about left bundle branch block. Okay. So the answer over here is nothing but left bundle branch block. Clear, guys? Okay. All right. Now, do I have to do anything if a patient has left bundle branch block or right bundle branch block? Do I need to check anything? Do I need to do anything? You also need to know what is the next step to be done in this case. Any idea, anyone? Okay, so remember, if my patient has a right bundle branch block, that can be normal also, or it can be because of pulmonary hypertension, or it can be because of some lung causes like COPD. Okay, but in case of left bundle branch block, I have to be very, very careful. Left bundle branch block is often seen when the patient has some kind of acute coronary syndrome. So if the patient is having LAD or left circumflex block, in that case, I can get left bundle branch block on the ECG. So if patient is presenting with LBBB, I will investigate it further. I will go ahead for a resting 2D echo, look at the EF of the heart, look at how the left ventricle is contracting, and if required, I'll get a coronary angiography to check if the left side of the heart is having, left-sided circulation of the heart is having any blockage in it. Okay, so that is what you should be able to answer in the exam. Okay, moving on to our next ECG. Heart rate on palpation is 80 beats per minute. What is wrong with the ECG of this patient? So you are palpating, imagine you're palpating the carotid and you're getting a heart rate of 80 beats per minute. And then you look at the ECG of the patient. So what is the heart rate on the ECG? Anyone? What is the heart rate on the ECG? This is a regular rhythm. So heart rate on the ECG will be 300 divided by 1, 2, 3, 4, 5, 6, almost 6 small squares. So the heart rate on ECG is 60 beats per minute, 50 beats per minute, and the heart rate on palpation of carotid pulse is 80 beats per minute. So what is wrong? Is the ECG wrong or is the palpatory method wrong? What is wrong with the patient in this case? Why are you getting a different heart rate? Very good, Deepti Sharma. Excellent. So what is happening over here is your heart rate on the ECG is 50 and heart rate on palpation is 80. Now whatever you're palpating definitely cannot be wrong. You can feel the pulse, correct? So this will be the correct heart rate of the patient. But the ECG paper speed over here is not correct. Okay, so this is the problem with the ECG paper speed. So can anyone tell me what is the normal paper speed when you're recording an ECG? When you're recording an ECG, what is your normal paper speed? Do you know how many millimeters per second? Okay, so when you're recording an ECG, the normal paper speed is 25 millimeters per second. Okay, so when you have an ECG paper, just imagine, which is moving very, very fast. So if the ECG paper is moving very fast, if it's moving at double the speed at 50 millimeters per second, it won't be able to mark the QRS complexes very too many QRS complexes because it's moving so fast. So it will mark the QRS complexes very far and wide apart. Okay. On the other hand, imagine you have an ECG paper which is moving very slow. So it has many opportunities to mark QRS complexes because it's moving slowly. Okay. So if the ECG paper is moving slowly, it marks more QRS complexes. If it marks QRS complexes, your heart rate it shows is falsely high. Okay. On the other hand, if you have ECG paper moving very quickly, so the QRS complexes it marks is very less. So that means this is the fast moving paper. Here, if the QRS complexes are marked very far apart from each other, it is showing a falsely low heart rate. Okay. So what am I getting over here? I'm getting on ECG, I'm getting a falsely low heart rate. I'm getting a heart rate of 50 when in fact on the other hand on palpation it is 80. So when I'm getting a falsely low heart rate, that means my ECG paper is moving very fast. So I can conclude that my ECG paper may be moving at around 50 millimeters per second instead of the normal 25 millimeters per second. And that's why I'm having this false ECG heart rate. Okay, so I have to depend on the palpatory method only over here and then correct the ECG paper speed and then come to it, right? Okay, now diagnose this ECG. What is the diagnosis of this ECG? In fact, I have given you a small hint also in the ECG. Yes, very good. Excellent, Deepthi. So, what are we getting over here? I have marked the PR interval over here is 0.34 second. Okay. So, what is your normal PR interval? Anyone, what is your normal PR interval? Batao. Yes. So your normal PR interval is 3 to 5 small squares. Barabar? If each small square is 0.04 seconds, so your normal PR interval will be 0.12 to 0.20 seconds. Correct? So here the PR interval that you're seeing is 0.34 seconds. So if you're seeing that the PR interval is prolonged, then very simply the diagnosis is prolonged PR interval means you're having a heart block. Now, you need to know what kind of heart block is this. Is it first degree heart block? Is it second degree heart block? Third degree heart block? If it's second degree heart block, whether it is Mobitz type 1 or Mobitz type 2. So, if you look at this ECG very closely, you have your PR interval is prolonged, but the PR interval is constant. Okay, and every P is followed by a QRS complex. So, if your PR interval is prolonged but constant, then what is the diagnosis in this case? It is nothing but first degree heart block. Okay. Now you have to tell me how will you manage this patient with first degree heart block? Anyone, can you tell me what is the management of the patient with first degree heart block? This is a prolonged PR interval which is constant and every P is followed by a QRS. So what is your management of first degree heart block? Pacemaker. Okay, no, you don't need to put a pacemaker. You need to monitor this patient and look at the hemodynamics of the patient. If the patient is hemodynamically stable, then you don't need to do anything. In most of the cases, these patients are hemodynamically stable. So nothing is required in first degree heart block. Okay. Only if the patient becomes hemodynamically unstable, then you may need to pace the heart temporarily, transvenous pacing or transcutaneous pacing, and if it remains like a permanent phenomenon, then you need to put a pacemaker. But most of the times, your hemodynamics will be stable in a first degree heart block. Okay, so you just need to monitor the patient. All right, moving on to our next ECG. Anyone identify the ECG similar to something that we saw in the previous ECG? Okay, is it Mobitz type 1 or is it third degree? Batao. Two people are confused. Is it Mobitz type 1 or third degree? Okay. So if you look at the very obvious thing over here, the QRS complexes that we are having are all equally placed. Barabar? At least I can see that the QRS complexes are equally placed from each other. So the RR interval are constantly occurring. The distance between the RR interval is constant. Okay. So when my distance between RR interval is constant, what do I look at next? Next, I have to look at the distance between my PP waves. So if I look at the distance between my PP waves, okay, so let's have a look over here. This is my P wave, then the next P wave is here, then the next P wave is here, then after that the next P wave is here. So nearly my PP interval is also remaining constant over here, correct? So the RR are moving with each other and the PP waves are moving with each other, okay? But there is no relation between the P and the QRS. So here P is followed by a QRS, here P is not followed by a QRS. Then here P is not followed by a QRS. Here P is followed by a QRS. Here there is no QRS. Okay. So it's all paka hua khichdi, pichdi. So this is definitely not a second degree heart block. What is this? This is a complete heart block. Everything is happening on its own. The PP interval are moving on their own and the RR interval are moving on their own. So this is a complete heart block, or it is also called as a third degree heart block. What will be my treatment in this case? Anyone? How will I treat this patient of complete heart block or third degree heart block? What will be my treatment? Yes, very good. So I will insert a permanent pacemaker in this patient. I will insert a permanent pacemaker in this patient to pace both the P waves and the QRS waves. All right. Okay. Next one. Okay. Deepti is saying Mobitz type 2. Any other answers? Yes, Staphylococcus is also saying the same. So that is correct. So what are you getting over here? You see the P wave and the QRS complex. P wave, QRS complex, P wave, QRS complex. Now your PR interval over here is normal. Okay. But what are you having? Suddenly you are having P wave and there is no QRS. So you have a dropped QRS complex. So initially your PR interval was normal and then you have a drop QRS complex. So after every 3 normal beats, you are having 1 dropped beat. Okay, 3 normal beats and then 1 drop beat. So this is the ratio of your block. So this is called as a ratio block. A ratio block is seen in second degree heart block. Now second degree heart block has 2 types, Mobitz type 1 and Mobitz type 2. So a ratio block is seen in Mobitz type 2. So this is nothing but your second degree heart block, Mobitz type 2, with a ratio of 3:1. Again, the treatment for this, if the patient is hemodynamically stable, no need to do anything. If unstable, then we will consider putting a temporary or a permanent pacemaker in the patient. Alright? Okay. Identify. What is wrong in this case? Anyone identify? Okay, Staphylococcus is saying it is Mobitz type 1. Any other answers? Yes, so this is the only heart block that was remaining. Absolutely correct. So what are you seeing over here? Again, you are seeing that somewhere over here also you are having a drop QRS complex, correct? But now you need to know that, see, remember, whenever you are having dropped QRS complexes, in case of drop QRS complex, there is only one diagnosis, and that is second degree heart block. Second degree heart block. Okay. Now, just look at the PR interval over here. Here it is normal. Then here it is slightly increasing. Here it is increasing even more, and suddenly you have a drop QRS complex. It's not like the previous one in which the PR interval was normal, 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 and then suddenly drop QRS. Here, the PR interval is constantly prolonging. It is constantly prolonging, and then you have a dropped QRS complex. Alright, so this kind of heart block is nothing but second degree Mobitz type 1. And this is called as the Ventricular phenomenon. Ventricular phenomenon. Okay, now to help you guys remember all the different types of heart blocks, I'll tell you the story of the heart blocks. Okay, so imagine that you are initially there are Raj and Simran, and they are dating each other, and they both live in Mumbai, and then they decide to have a long distance relationship. Okay, so since they are so much in love, they decide that at the end of every month they will meet each other. So Raj is in Mumbai, Simran is in Delhi. They decide that at the end of every month we will meet each other. So their meeting interval, okay, is prolonged, but it is constant. It is at the end of every month. So this is the initial part of their long distance relationship, that is first degree heart block. Okay, now the next thing that happens is second degree heart block. So in second degree heart block we have Mobitz type 1. So here we will know whether Raj is a good boyfriend or a bad boyfriend. So if Raj is a good boyfriend, what will he do? He will make sure that he comes to meet her at the end of every month, and then the 4th month he will take a break. Okay, so he'll say that, baby, Mumbai Delhi rates of flights are quite high, I cannot afford to come every month. So if he is a good boyfriend, he will inform her prior only that I'll come 3 months, at the end of every month, 1 month I will take a break. So he is giving her a ratio block. So here he is a good boyfriend, so Mobitz type 2 is a good boyfriend. On the other hand, if Raj decides all of a sudden that no, I am not going to tell her that I won't come every time, what I'll do is, first I'll meet her after 1 month, then I'll meet her after 2 months, then I'll meet her after 3 months, then I'll one fine day I won't turn up at all, then again I'll go whenever I want. So what is he doing? He's prolonging the meeting interval without telling Simran. So here he is a bad boyfriend. So Venki back that we have, Venki back phenomenon or Mobitz type 1 is a bad boyfriend because he keeps on prolonging the meeting interval without telling his girlfriend. Okay. And then finally, what happens in every long distance relationship? There is a complete heart block. So they decide to call it quits. They decide that it's not working out in this long distance relationship. So let's go away from each other. So Raj is the QRS complex. He is having his own life. He is having his own intervals. And Simran is the P waves. She is having her own life and she's having her own intervals, and they are not meeting with each other at all. Okay, so there is no relationship between P and the QRS. So that is complete heart block or third degree heart block or the breakup of the long distance relationship. Okay, so that is how you remember the entire ECG pathway of the heart blocks. All right. So I hope that was useful to you guys. Now moving on to our next ECG. So identify what is wrong with this ECG. दूसरा कोई मिल गया होगा, हो सकता है. Okay, so here in this ECG, what can you see very glaringly? Again, as I told you, how do you go? You look at the rate, you look at the rhythm, you look at the axis. Okay, so you can see over here the RR interval is constantly changing, so the rhythm is irregular. And what about the rate? The rate will be calculated. Can anyone calculate the rate in this case? I'll give you the 15 big squares. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Okay, so these are 15 big squares. You are having 4 QRS complexes over here. So what is the rate? Since it is an irregular rhythm, 4 multiplied by 20. So the rate here is 80 beats per minute. Okay. Now, even though it is an irregular rhythm, every P is followed by a QRS. Every P is followed by a QRS. So what is this? This is called as sinus arrhythmia. So this is a very normal occurrence. Remember, when you breathe, when you inhale and when you exhale. Okay, so when you inhale, you have an increase in your heart rate. Okay, and when you exhale, you will have a decrease in your heart rate. So that is why you get the arrhythmia that is called as sinus arrhythmia. Okay, clear? All right, moving on to our next ECG. No, Staphylococcus, this ECG is absolutely physiological. When you normally inhale and exhale also, you get sinus arrhythmia. Yes, very good, Deepthi Sharma. You are absolutely correct. So what I'm getting over here is nothing but a VPC, okay? So you can see over here your P wave, QRS, everything is normal. But suddenly you have a weird looking QRS complex over here, which is not preceded by a P wave. It's just coming somewhere in between, okay? So this is called as a ventricular premature contraction. This is called as a ventricular premature contraction. So ventricular premature contraction, how does it exactly occur? So if you look at the heart over here, okay, these are my ventricles. Just imagine that here there is an ectopic focus, and this ectopic focus is just firing beats of its own. Okay, so the normal pathway that we have of the impulse generation from the SA node to the AV node to the bundle of His and the Purkinje fibers and right and bundle branch block is normally happening, and the heart is beating. But suddenly, beach mein jhatka aata hai and this ectopic starts firing. Okay, so when this ectopic fires, it gives rise to this ventricular premature contraction. Now, how does this ventricular premature contraction look? It basically looks like a wide QRS. Why does it look like a wide QRS? Because this impulse, this ectopic impulse, instead of spreading through uh, the highly conductive bundles, so the highly conductive tissue, it will spread through the ventricular muscle. And when it spreads through the ventricular muscle, it spreads very slowly. So if it spreads very slowly, it takes time for the ventricle to contract. So that is why you get a wide QRS complex. So this is called as a ventricular premature contraction. Okay. No, staphylococcus in normal ECG, your rhythm can be irregular also. It's not necessary. It has to be a regular rhythm only. If every P is getting followed by a QRS, then, and that kind of irregular rhythm, it is called a sinus arrhythmia. It happens when you breathe. It happens in young patients also when they breathe normally. Okay, due to the changes in inhalation and exhalation. Alright, so this is how a ventricular premature contraction arises, and this is how it looks like. Now, what is the treatment for this ventricular premature contraction? So, if it is not causing, see, remember in ECG always, if it is not causing any kind of critical issue, like a hemodynamic instability, hypotension, or patient is not getting palpitations or syncopal attacks, you don't need to do anything. You just need to keep a watch that it does not increase. Okay, but if it does cause hypotension or syncopal attacks, then you need to treat this. So you can start the patient on lignocaine. This is an antiarrhythmic, and that will help in reducing the chances of these VPCs. All right. Okay. Next, identify this ECG and tell me the treatment. Yes, staphylococcus. So what is the diagnosis of this ECG? Anyone? Simple ECG. Yes, very good. So what are you able to see? The QRS complexes over here are normal narrow QRS complexes, but the problem is in the P waves. Okay. So what do the P waves look like? The P waves look like sawtooth waves. Barabar? They look like sawtooth waves. So they are also called as flutter waves. So the sawtooth waves or flutter waves are seen in case of atrial flutter. And similarly, we have one more ECG over here. Okay, 1 second. This one. Can you identify this ECG for me? No, that was atrial flutter. This ECG, can anyone identify for me? Look closely and go by the formula I told you, rate, rhythm, axis. Yes, very good. So what are you seeing over here? You're seeing that first of all, when you look at long lead 2 over here, you can see the heart rate is irregular. Okay, there is irregular rhythm, and along with this irregular rhythm, you see that there is no P waves that are present. There is absent P waves. So this is nothing but atrial fibrillation. Okay, absent P waves seen in atrial fibrillation. All right. So since this is atrial fibrillation, what do you do for the treatment of atrial fibrillation? Again, AFib, it depends on the timeline as well as it depends on the hemodynamic stability of the patient. So remember, if the patient is coming with low BP along with atrial fibrillation, then you will go ahead with cardioversion. Okay, cardioversion is application of shock around 100 to 150 joules, and it is synchronized with the QRS complex. Okay, suppose there is atrial fibrillation but the BP is normal, then you go ahead with ABCD drugs for the treatment. You don't need to cardiovert. You can use amiodarone, beta blockers, calcium channel blockers, or digoxin. That is ABCD drugs for the treatment. Okay. Again, before cardioverting the patient, you have to know whether this atrial fibrillation is present for more than 48 hours or not. If it is present for more than 48 hours, that means there could be formation of a clot in the left atrium. If you cardiovert and the patient goes back to sinus rhythm, that clot can go from the left atrium to left ventricle, from left ventricle to the cerebral circulation and cause a stroke. Okay, so what you want to do is you want to stop that from happening. So if the patient is having AFib for more than 48 hours, you first do a 2D echo, look at the presence of the left atrial clot or not. If the left atrial clot is not present, go ahead with cardioversion. If the left atrial clot is present, then you will have to anticoagulate the patient, and then once the clot has dissolved, then you can cardiovert or correct the rhythm of the patient. Okay, so that is the treatment for atrial fibrillation. Very important. This comes in the exam, treatment of atrial fibrillation. All of you all should be aware of it. Okay, look at this ECG and identify. Okay, absolutely correct, Staphylococcus. So what are you getting over here? This is nothing but you can so if we look over here, what is the rate? The rate is definitely more than 150 to 200 over here. Okay, then what is the rhythm? You cannot comment on the rhythm because you can't see the P waves at all. Okay, you can see the RR interval is constant, but the P waves are not seen. And what is the P wave pattern? P wave not seen. What is the QRS wave pattern? QRS that you see over here is wide QRS and it is same looking. Okay, so the morphology of all the QRS complexes is similar. So morphology of all QRS complexes is similar. So what are you getting over here? This is nothing but a ventricular tachycardia. This is a ventricular tachycardia. Okay. Now ventricular tachycardia mein you need to know what is the diagnosis, how do you treat it. So whenever you get VTAC, broad QRS complexes, first of all you need to identify whether this is monomorphic or polymorphic ventricular tachycardia. Correct? So monomorphic ventricular tachycardia means all the wide QRS complexes look the same. Okay. One second, I'll just okay. When your neighbors are reconstructing, renovating their houses, and you want to take a class. Okay. So monomorphic ventricular tachycardia is when all the QRS complexes look the same. So you can see over here all the QRS complexes are looking the same. So this is the monomorphic type. In polymorphic type, you will have all different looking QRS complexes. Okay. What is the morphological difference? If this is my heart, a monomorphic ventricular tachycardia source will be from a single ectopic source in the ventricle. But if I'm getting polymorphic ventricular tachycardia, I will be having many sources in the heart which are ectopics and giving rise to the QRS complexes. Okay, so you can see over here. So since all these look the same, that means they're coming from a single source in the heart. Okay, now the next thing I need to see is whether this is with pulse or without pulse. So is this pulseless VT or is this with pulse? Okay, so if I am having ventricular tachycardia with pulse, I can go ahead with this treatment by giving antiarrhythmics. But if with this kind of ECG, I'm not feeling the pulse of the patient, I'm trying to feel the central pulse, carotid, I cannot feel the pulse of the patient, then what am I supposed to do? This is called as pulseless ventricular tachycardia. So pulseless ventricular tachycardia mein, I have to go ahead and I have to treat this patient like a cardiac arrest, okay? And this will require a defibrillatory shock. So when remember, pulseless VT is a type of cardiac arrest rhythm, but VT with pulse is not a cardiac arrest rhythm. Okay, Krishna Prasad is asking how to differentiate from ventricular flutter. There is no ventricular flutter, there is atrial flutter. So you can look at this. This is atrial flutter. Your QRS complexes are narrow and they are normal, and they are preceded by flutter waves, sawtooth waves or flutter waves. And this is ventricular tachycardia, in which you have wide QRS complexes only and no P waves. All right. Okay. Next ECG. Identify. I have also given you a small hint over here by circling the problem. Okay. Very good. So what am I able to see over here? Can you see your PR interval? Your PR interval over here has become very short. Okay, so your PR interval is narrowed. Okay, and what does this look like? If you see, the P is almost onto the R, QRS complexes. Okay, so this looks like a delta wave. This looks like a delta wave. So this is presence of delta wave, and this delta wave is seen in which case? It is seen in case of Wolff-Parkinson-White syndrome. Okay, so this is WPW syndrome or Wolff-Parkinson-White syndrome. Okay, all right. Identify this ECG. ST elevation, no? Can you see something that is unconventional over here? Presence of these spikes. Do you usually get these spikes? So you have a spike followed by a contraction of the ventricle. Spike followed by a contraction of the ventricle. Spike followed by a contraction of the ventricle. Any idea what we are talking about? Yeah, very good. So this is nothing but a pacemaker. Okay, so the spike that you can see over here is nothing but a pacemaker spike. Okay, so basically whenever the pacemaker spike comes, after that the ventricle is contracting. So once the pacemaker passes the impulse to the ventricle will contract. So that is why you get this abnormal looking QRS complex. So your ventricle is getting paced in case of this pacemaker spike. All right. This you will see in long lead 2 staphylococcus. Here, any idea? This is the last ECG for today. Since we are having a lot of disturbance, we'll stop with this. Yes, absolutely correct. You can see ST elevation. In which leads do you see ST elevation? Okay. So you can see ST elevation in V2 and V3. I agree with you. But along with that, you can also see one more very obvious change over here. Can you see one very obvious change over here? Look at the long lead 2. What is this called? Hockey stick sign, reverse tick mark sign. In which condition do you see this? Hockey stick sign or reverse tick mark sign. That is also a very, very obvious change over here that you can see. Yes, very good. So this hockey stick sign or reverse tick mark sign is seen in the case of digoxin toxicity. Okay, digoxin toxicity. Alright. Now look at this ST elevation versus this ST elevation. So if I had to go with an answer for this ECG, more than ST elevation, I would rather go with the reverse tick mark sign. Look at over here how the ST looks. It literally looks like a mountain, correct? So here you can see the ST elevated like a plateau or like a mountain in V1, V2 and V3. Barabar? Yes, absolutely. So what is this diagnosis? Here the diagnosis is MI. Now which wall MI is there? You need to tell me looking at the pattern of the ST elevation. Okay. So here I can see ST elevation in V1, V2 and V3 and V4 also. So can you tell me where is the MI? So V1 and V2 is MI because I mean if V1 and V2 are showing ST elevation, that means the septum is involved. If V3 and V4 are showing ST elevation, that means the anterior wall is involved. Okay, so I am having a anteroseptal MI. Okay, similarly, looking at the next ECG. What can you see over here? So again, you're seeing ST elevation. Where do you see the ST elevation? In 2, 3 and AVF. Yes, absolutely correct. So when you are seeing ST elevation in 2, 3 and AVF, that means you are having inferior wall MI. Okay. Next. Here, any idea? Where am I seeing the ST elevation over here? In 1 AVL, V5 and V6. So the ST elevation over here is in 1 AVL, V5 and V6. Okay. So what am I getting over here? This is nothing but lateral wall MI. This is lateral wall MI. Okay. Next ECG. What do you see over here? something that we already discussed in this class now. Anyone, any idea? Chalo, this has been discussed in the class previously. Okay, so look at the QRS complex over here. It's very obviously wide. Okay, and what pattern am I having over here? I'm having the M pattern. This is the M pattern, correct? So what am I having over here? I'm having right bundle branch block, correct? Along with that, look at my axis. My axis over here is leaving each other. 1 and AVF, QRS is leaving each other. Okay. So this is LAD plus RBBB. Now remember, whenever I have RBBB, I have to see whether there is left axis deviation or right axis deviation. If I am having left axis deviation along with RBBB, that means I am having left anterior fascicular block. Okay. If I am having right axis deviation along with RBBB, that means I am having left posterior fascicular block. What do you mean by this? I'll draw the heart for you guys and just have a look over here. So you have the left bundle branch and you have the right bundle branch. Now this left bundle branch divides into left anterior and left posterior bundle branch. Okay. So if I am having the left anterior bundle branch getting blocked along with the right bundle branch, that is called as the bifascicular block. And if I am having the left posterior bundle branch block along with the right bundle branch, that is called as also the bifascicular block. Okay. So if the left anterior bundle branch is blocked, then that is LAD. If the left posterior bundle branch is blocked, it's right axis deviation. Okay, I think this noise is getting a little too much now. So we'll conclude our class over here. I hope that this class was useful to you guys. We do have a few more ECGs left. Tomorrow we'll be having 2 classes at 3 p.m. and 6 p.m. So I'll update you guys about the class timings beforehand on the Telegram group. And then we can go ahead. Right now there's too much disturbance, I guess. So it's better to continue tomorrow. Okay. All right. So I'll see you guys tomorrow. Bye. Till then, take care and keep studying.